If you're watching this video, there's a good chance you've been dealing with pain, swelling, or drainage in a place you're not comfortable talking about. Maybe you've been to a doctor who told you to just let it heal on its own. Maybe you've had surgery that didn't work and it came back. Or maybe you just Googled your symptoms and ended up here. Either way, I'm glad you found this video because pilonidal disease is one of the most misunderstood and undertreated conditions in surgery. There are better options than what most patients are being offered. I'm Dr. Som, a board-certified plastic and reconstructive surgeon and a board-certified general surgeon. I've spent years researching and publishing on pilonidal disease, and today, going to walk you through exactly what it takes to reconstruct and deal with this problem, and what's happening to cause and have it come back over and over again. What are some of the modern reconstructive techniques, approaches, and the recovery associated with this? Let's start with the basics. Pilonidal disease is a condition that occurs in the gluteal cleft. That's the crease or space between the buttocks. It typically shows up as a cyst or an abscess, a pocket of infection, or a little sinus tract, essentially a tunnel underneath the skin. It's usually caused by hair follicles growing inwards instead of outside, so little bundles of hair can be found within the cyst. And then it builds up from pressure and friction to cause trauma in that area. That trauma causes an irritation and the reversal of the hair follicles in the simplest way of thinking about it. Over time, a pocket or a cyst is formed, and that can collect and form with infection as the debris builds up in the hair follicles within it. As an infection worsens, you can have swelling, pain, purulent drainage, and then necessitate more treatment and therapy. Now, who gets this? It's more common in younger patients, typically between the ages of 15 and 35, and more common in males. It's more common in people with coarser or thicker body hair. It's more common in people who sit for prolonged periods of time, which is why historically it was called the Jeep driver's disease during World War II. People who would be sitting in the Jeeps with a lot of trauma or sitting in the trenches, that recurrent trauma to that area caused the damage. But I want to make something very clear. It's not a hygiene issue. There are patients that are very hygienic, lots of care, washing repetitively, and are very embarrassed, thinking they did something wrong. You didn't. It's an anatomical and mechanical problem. The shape of the cleft, the direction of the hair growth, trauma, these are all things that you can't control. And the question that I hear very calmly, Dr. Som, I already had surgery. Why is it back? Or why hasn't the first surgery healed and they've been having months of therapy elsewhere and then end up coming to us? It comes down to how the first surgery was done. The traditional approach, and this is still taught to most general and colorectal surgery programs, is called an excision that's left to heal by secondary intention. What does that mean? The area is cut out and left open. So you have raw subcutaneous tissue that needs to start filling in on its own with time. That works very well and is very effective at preventing recurrence, but it's raw exposed tissue, very painful, can take a prolonged period, weeks to months, and there are alternative methods to help. One of those is doing a flap to close the area. What does that mean? That's where we mobilize the sides of the tissue, pull it together, and create a scar in the midline. It's one of the most cosmetic ways of doing this and works fairly well. There are multiple variety of different flaps that have been put in the literature, rotational flaps, rhomboid flaps, multiple different ways, but the highest recurrence rate happens for patients that are chronically exposed to this and don't get the complete excision to begin with, or the repeated trauma that they continue can make it recur. Scar tissue in the midline can create the exact same condition that caused the problem to begin with. The skin is tight, the cleft is deep, and the hairs can end up growing in the wrong way again, and the cycle starts all over again. That's why our approach is a little bit different. We try to do the reconstruction to begin with, get people back to their lives as quickly as possible, and if there is a problem, we can do multiple steps to try to help with the recovery and shorten the recovery period. That's why rather than leaving it open, we close it using those special tracks to minimize the recurrence and align the hair in the right direction. It decreases the chances of recurrence, improves the chances of recovery, and overall improves quality of life for patients. The result is a flatter contour. The scar sits in a more favorable position, and we've aligned the hairs a little bit better, and the scar is much more cosmetic as an outcome, being right in the midline. The other benefits of being closed from day one: faster recovery, less pain, lower chance of recurrence. In our published data, the recurrence rate was in the 10s to 20% at the highest level on people that were very high risk, but for most in the single digits. This is a meaningful difference for a lot of people out there that could avoid having an open wound to begin with. There are some restrictions in the level of activity they can do. We restrict heavy lifting, prolonged sitting, and there's a whole pathway and guidelines that we'll give you from day one to help optimize your outcome and recovery. The outcome could be dramatic difference in experience for most patients. And I see a lot of patients who come to us after 1, 2, sometimes 3 prior surgeries. They've been told that this is going to be a lifelong problem, and we're able to help get them through this. Very commonly, we see patients that have had prior surgeries, and we end up being their 3rd, 4th surgery, which is one of the things that we specialize in, is doing the definitive reconstruction after prior surgeries. It makes it a little bit harder because the anatomy is already distorted, but the principles are the same, and that's how we treat it. We excise the wound and start out new, recruiting healthy tissue from the surrounding areas to rebuild and reconstruct this deficit and optimize their outcomes. If you've had surgery that didn't work and you're out of options, we're here to give you a more definitive approach with the experience and care that we can provide with our team, help get you through this problem. And to address the idea of a pilonidal healing on its own, that is not going to happen. Once that cyst is formed and gotten infected, it has to be removed or it will continue to be a problem. Antibiotics are key in the acute setting of an infection, as well as releasing any of the abscess fluid that's there. But the sooner it's addressed properly and the sooner we do the reconstruction, the sooner people can regain their quality of life and return to normal function. If you've already had surgery elsewhere that didn't work or just starting to have the disease, I'd encourage you to reach out to our office. We offer consultations both in person as well as virtually, and we're happy to help review your case and walk you through your options. I'm Dr. Som. Thank you for watching. I'll see you in the next video.